So this was really an effort led by one of our fellows, Dr. Emmett, which was a great thing. But I think we've known for quite some time that MAP kinase pathway alterations, particularly KRAS and BRAF alterations, are sort of negative predictors of benefit from EGFR targeting in colorectal cancers. And there have been some efforts to characterize what happens to patients who are treated with EGFR monoclonal antibodies and then develop acquired resistance. How are the tumors evolving? Are there patterns of specific mutations that are converging around conserved pathways of resistance? And there has been some really nice work in this field, including a clinical trial looking at rechallenge. And we wanted to take a very large real-world cohort that had colorectal cancers that had been subjected to large panel-based sequencing, in this case, the Foundation Medicine platform. So we looked at a large cohort of patients who had treatment in the front line and later line with EGFR monoclonal antibodies from what's called a clinical genomic database. It's essentially patients who are sequenced and also had outcomes data. And the first point is that the real world data largely reflects the trial population. So it helps us to know that our data can probably be contextualized and compared to some of the trials that are out there. So the second thing is that we were looking again at some known patterns to see if the things that had been described were held up in our real world data. And largely this is true. Patients who had MAP kinase alterations, other receptor tyrosine kinases, including HER2, had less favorable outcomes. And then we looked a little bit specifically at what were the actual mutations. And we saw some known things, including secondary mutations in EGFR, which reduced the binding or the ability of Panitumumab or Cetuximab to bind. And then we saw mutations that turn on downstream signaling or offer a bypass to retain signaling for the tumor cells. This might be MET amplification, KRAS amplification, specific KRAS alterations, MAP kinase or MEK alterations. And really what we went on to show is that there is some relationship between the development of these mutations and the time on EGFR therapy. So this is really not a big surprise, but the longer the tumor is feeling the pressure of an EGFR antibody treatment, the greater the chances that it will ultimately develop a resistance mutation. And so all of these findings, the lack of benefit in certain populations, the specific mutations we found, and the association between time on treatment and resistance mutation presence are sort of expected, but I think this may be the first time that they were shown in a large real-world cohort, suggesting that these types of data can be very informative and help provide additional support for clinical trials, especially in rare populations where clinical trials can sometimes be difficult.